Okay, Dr. Kate Collins, I'm so thankful that you took the time to chat with me today about what C-section looks like for people, because I'm sure you have questions all the time as well when clients or patients come in, maybe they are planning to have a C-section, or you think there's a chance they might have a C-section. And I really look forward to using this time to kind of answer some of the questions that I know these women have. And I'm very appreciative that you took the time to do this.
My absolute pleasure. Thanks for having me.
So it was funny. I was actually reading a book the other day that was talking about that, research sees that three factors that universally cause stress are uncertainty, loss of control, and lack of information. And so I see this as being, I thought about birth right away. And I think, like, no wonder so many people are nervous about birth, because that kind of covers all of it.
Yeah.
And I see this as a time to maybe answer some of those questions. So before we get going, would you tell everybody a little bit about you, just so that they know kind of where you're located, what your practice is, and your expertise?
Sure. So I'm a general obstetrician gynecologist and I work in Kelowna, BC. So I've personally performed countless C-sections. And then I have actually also personally had two C-sections, both an emergency C-section and a planned C-section. So I think I kind of have a bit of an experience on both sides, which is
Absolutely.
hopefully helpful.
And I think I'll just make sure, because I'm pretty sure that I can say with confidence that as we talk today, we're going to be talking about what happens at our local hospital, and we can't always speak to what happens in other locations. So obviously kind of keep that in mind as people are listening, and maybe just opening conversation with their own care provider in their own community.
Absolutely.
I wanted to talk today about kind of the anatomy of a C-section. I want to talk specifically about what happens in a C-section, but maybe some things leading up to it first. What happens, let's say you have somebody, let's say it's me, and I find out, whatever it be, from an ultrasound or something else in our appointments come up, that I'm going to have a planned C-section. Can you tell me, first of all, how often, how far in advance does someone know their C-section date? What's kind of taken into consideration there?
Sure. So it will depend a lot on the reason why you're having a planned C-section. So the person who's probably going to know the furthest in advance will be someone who has had a previous C-section and is choosing to have a planned C-section, or who has had a type of C-section or more than one C-section that requires them to have a planned C-section, because that's something sort of right from the get-go. In that scenario, at our institution, we can book a date for you about, I think it's 12 weeks before your C-section date. So it's a fair amount of lead time, certainly far more than, other planned surgeries get, because our surgical booking office usually only books about 3 weeks ahead here, but that's going to vary wildly depending on what institution you're working at. But certainly there are also a number, there are certainly conditions that occur during pregnancy that might necessitate C-section, and then it might be less. Like, for example, another common reason for C-section would be breech at term, and then you're not going to know that you even need a C-section until you're 37 weeks. And so then you'll only have and then the goal would be to deliver you around 39 weeks. So then you would only have a couple of weeks of preparation time. The other thing that I think all hospitals have to work with is that OR time, like operation surgery times, are a finite resource. So we only have so much time allocated to us. So we can certainly run into situations where all of the time that's allocated has already been scheduled for people. And I think the one big thing that women need to know is that I think every single institution will still make your C-section happen in a timely and appropriate manner. It's just they might not be able to give you as much notice, which is, I think, a really challenging thing for patients in general, and particularly, I think, for C-section, because they are, having to coordinate so much in terms of often care for other children. Partners need time off work. It's not just, they're not living in isolation. And certainly we are very cognizant of that. And so we do our best to give people as much notice as possible.
So what would happen? And obviously that, once you know that you have different appointments with them, they're still being followed by their kind of maternity care provider quite often. So, time to ask questions and go through some of the events that are to come. But as a general rule, what are some of the things that someone could expect the day they show up at the hospital for their scheduled C-section?
Yeah, so most of the time, you'll be asked to come a couple of hours before the sort of estimated or planned time of your surgery. And then typically you'll have been, I guess on the day of, yes, you'll be asked to come in a couple of hours beforehand. Typically you won't have been eating or drinking for a number of hours beforehand, and the hospital will have told you what time to stop eating and drinking. You're brought in and they sort of they get you changed, they get your support person changed into scrubs so that they can come support you by the bedside. You're typically in an area that we call like pre-op or pre-surgery, the pre-surgery area. You'll have an IV started. You will meet with some of the nursing staff. You will meet with your anesthesiologist who will answer any questions that you have. And you'll meet with your surgeon, and depending on where you're at. So at our hospital, typically your surgeon is the same obstetrician that you have met previously, but there are certainly many hospitals where the volume of patients doesn't allow that. And at those centers, it's often the obstetrician on call. So you may actually be meeting the surgeon who's doing your C-section for the first time that day. But you're always welcome to ask any questions that you have at that time. And then once sort of you've met everybody and they've gone through there's a bunch of safety checklists, then typically you're brought into the operating room, where again, and your support person is not brought in quite yet. And that can be quite, I think, scary for some people, because the operating room can be a bit of an intimidating place, but it's important to know that everybody there is there to take care of you. But it's quite a big team. And I think that can be surprising for people, because you have at minimum 3 or 4 doctors. So you have your anesthesiologist, the surgical assistant, who is typically a physician of some kind, and then often as well a pediatric physician. So it's 3 or 4. And then there's a whole nursing team as well. So we have a scrub nurse who is scrubbed in. There's a circulating nurse who is getting anything that the surgical team needs. And then typically also there would be another nurse helping, and often the pediatrics team will also have nurses present. So it can be quite a big birthday party. And I think that can be quite intimidating.
That's a good way to look at it. A birthday party.
I think it's a big birthday party. Yeah.
What's the big difference then if it becomes an emergency C-section? I imagine it's kind of the same protocol, same people, just faster.
Yes.
Yeah.
Yeah. Yes. And certainly like the decision time and your leeway in terms of how much notice you have is very different. And with an emergency C-section, it really varies how fast things move, really vary depending on why we're doing it. So if it's an emergency where there's no immediate risk to your life or baby's life, then things actually still move fairly slowly. Like it can be still a number of hours between the decision to move to C-section and actually delivering baby. But then in situations where there might be imminent risk to your baby, then sometimes it does move very quickly. And I think that can be very overwhelming. I think it's still, we aim to make that decision again with giving you as much time to process things as we safely can. But it can be anywhere from, a few hours, like I was saying earlier, to really just a couple of minutes. But I would say the average is usually within an hour at our center.
And even in an emergency situation, the support person can come along, but the same process, they'll be outside of the room at the beginning. They'll be brought in. Yeah.
Exactly. And the reason for that is, one, we have to go through all of the safety checklists with you and make sure that the mom is being well taken care of. And also because we use regional anesthesia, ideally. So either an epidural or a spinal anesthetic. So you're awake. We have to make sure that that's effective. Because in rare circumstances, if it's not effective and you have to be put all the way to sleep, then we don't have your partner come sit by your side because you are asleep. But that's quite rare.
So is this something that you tend to talk through with people beforehand if this is a planned event? This is all something you would normally talk through with your
Yeah, I would
patients?
normally go through what to expect. And then we usually talk through the procedure itself and also what your hospital stay is like afterwards. And honestly, even in emergency situations, unless it's one where it's like we only have minutes, like as long as we have an hour or more, or even 30 minutes or more, like we talk through as much of all of this as we can. It's just that it's quite an acute situation. And I think it's really challenging to take it in that situation. But we certainly do our best to go through what to expect.
I'm curious to know on that note, do you find, kind of putting you on the spot with this, but do you find that you can tell some of the people, or maybe a difference between the ones that maybe are going into their second C-section? Like, do you see a benefit to people kind of allowing themselves to think through all these options, or think through the option of C-section, or prepare for it? Because I imagine for some people, a second time is like, okay, I know what to expect, and maybe it's a different experience. I guess I'm wondering do you have any suggestions for people to help prepare themselves for something that can seemingly feel very scary?
Yeah, I mean, it's hard because I think what's going to help each person is probably a little different. I think that in general, equipping yourself with as much knowledge as you can to think through it is beneficial so that if it happens, it's not something totally foreign. But it's, I think, but then I also have patients who would prefer not to know. Like I
Yeah.
don't want to know unless it's going to be happening. And that's very reasonable as well. And whatever, but it's important, I think, going into delivery to try to think through what you feel is going to be most beneficial for yourself. And then to try to equip yourself with the knowledge that you feel would be helpful. And I am someone where knowing all the possibilities benefits me, but I know that that's not the case for everyone. And certainly sometimes I have people who are going in to have a repeat C-section and they are actually more anxious because now they've had all this time to think about it, that they didn't have the first time around. And so certainly I think it can go both ways, and that's a bit challenging for people to navigate.
That makes sense. So if we kind of fast forward to now, it's time to actually perform the C-section. How do you prep the site? Like, what do you need to do before you actually do kind of the incision?
Yeah. So first when you come into the room, you have a hospital gown on, but you don't have any underwear or bra or anything on. And then we place you sit on the operating table. We do this safety checklist. And then the start would be the anesthesiologist placing your regional anesthesia, which is typically a spinal in a planned C-section. If it's an emergency C-section and you already have an epidural in place, they may either put more medication through the epidural to allow that to function for the C-section, or the anesthesiologist will choose to remove it and then do a spinal. And that's very much at their discretion in terms of how well the epidural is working and their own preference and your preference. And it's all. And then, so for that, they wash off your back and then they place the anesthesia. And once that's placed, then we lay you on the operating table, at which point your abdomen is uncovered and your abdomen is washed off with a surgical prep. We typically use chlorhexidine at our site. And then we also do prep your vulva and place a urinary catheter into your bladder to drain your bladder so that you can basically pee throughout the procedure. And also because if the bladder is very full, it's kind of like a little balloon and it will actually obstruct the procedure. So we want to keep the rest of your vital organs safe. And then we do often also wash inside the vagina with a prep, usually something called betadine because it helps decrease infection rate as well. And then once everything is sort of all what we call prepped or all washed off, then your surgeon and assistant and the scrub nurse are also all what we call scrubbed in. So we've scrubbed our hands and we're wearing sterile gowns and sterile gloves and masks. And we come and we put a big blue drape over your abdomen. At least at our center, it's blue, which has a hole over your abdomen where we can perform the C-section, but then keeps everything else sterile. And then typically they use that drape to sort of make a little wall in front of your face so that you don't actually have to watch your own surgery. And then at that point, as long as the anesthesiologist says it's okay, we check to make sure that your anesthesia is working well enough. So we use, we call them pickups or forceps, but they're kind of like giant tweezers, and we give you a really mean pinch. And typically what you will only feel is gentle touch or nothing at all. And that's what we're aiming for. You can sometimes during a C-section, you will feel touch and pressure, and it's a bit weird. And it just has to do with what nerve fibers the spinal anesthetic affects. So it affects it, keep you from feeling pain, but it doesn't keep you necessarily from feeling touch and pressure. Once all of that's done, this is typically the point where we'll bring a partner or support person in. And then the first step of a C-section is to make the skin incision, which is a horizontal incision, usually just above, sort of at the level of the top of the pubic hair line. And it's just big enough to get baby's head out. So that's typically what we aim for. And then we open up the fat that's underneath. The next step is to cut through a layer called the fascia, which is sort of the strong layer that holds everything in. And then we spread your muscles apart. So we don't actually cut them. We just spread them to the side. And then we enter your abdominal cavity. And your abdominal cavity is lined by a layer called peritoneum. So we enter that. And then once we've entered your abdominal cavity, basically we make sure that all of your organs, all of your vital organs are well away from where we're going to make an incision on your uterus. And then we make an incision on the uterus and break your waters and deliver your baby. And that's typically the fast part of a C-section. It actually happens quite quickly, usually within sort of 5 to 10 minutes. And when we're delivering the baby, there is often a lot of pressure because the surgical assistant is sort of helping to push baby out as the surgeon is lifting baby's head up. And so they kind of just slide out, but that can sometimes be a lot of quite intense pressure. But it's quick. It's very quick, like just a few seconds. And then at our center, we are typically doing delayed cord clamping as long as mom and baby are both doing well. So we will keep baby attached to the placenta for typically 1 minute before we clamp and cut the cord. And then at that point, we bring the baby over to the warmer for the pediatrics team to check them out. And I have worked at a few hospitals, and that has generally been the process at all of those hospitals. We do try, again, as long as baby is doing well, we try to sort of stop and show you baby on the way by. And then at that point, the pediatrics team will check baby out. And as long as they're happy with baby and baby's doing well, then you get to snuggle with baby up at the head of the bed while the rest of your surgery is being performed. And we certainly are supportive of doing skin to skin if you want. If you don't feel comfortable with that, or you're not feeling well, then partner or a support person is welcome to snuggle baby, but baby will be right there with you as long as they're doing well. And while that's happening, your surgeon is completing the surgery, which entails delivering the placenta and making sure that all of the placenta has been taken out. And then we have to close all of the incisions that we made. So we close the uterus incision, make sure that any bleeding is controlled. And then we sort of go backwards and make sure that nothing is bleeding. We close your fascia layer, that big strong layer I was mentioning that holds everything in. And then we close the skin. in terms of all up until the skin, all of that is done with absorbable sutures. So it's not like anything that's going to stay permanently, and it's not something you have to have taken out. And then when we close the skin, there's a variety of ways to close the skin. Typically either surgical staples or stitches beneath the skin of some kind. And then
one quick question.
Yeah,
I keep
sure.
hearing about some surgeons choosing to put some, and maybe that's what you were talking about when you said the fascia layers, but to put some extra suturing in the linea alba. Lots of people ask me that. Do the surgeons do this? And I said, you have to ask your surgeon, but I keep hearing
there's no good evidence for it.
Yes, there is no good evidence.
No, there's not. Because in fact, it's kind of interesting. Your abdominal cavity reperitonealizes or regrows back that peritoneal layer within 24 to 48 hours. So your stitches are just not really very necessary. And when I was training, certainly I did work with 1 or 2 doctors who would put stitches in the linea alba, but I'm not aware of any good evidence. And they tend to be stitches in the muscle, and sometimes stitches in the muscle can be quite painful.
Mm-hmm.
So my personal preference is not to, and I'm not aware of any good evidence supporting that decreases diastasis later.
And so did you say, can people expect, in our hospital, is everybody using like sutures then? Or no, depends. Sometimes staples, okay.
Exactly. And I think it's partly surgeon preference, partly patient preference, partly the actual scenario. So I think I'm the only one that routinely uses both. Like I do probably about 50-50. And it varies in terms of, I guess, simply how I think it's going to come together, which is very much not a scientific opinion, but there is actually a big randomized controlled trial study looking at long-term cosmetic outcome of C-section scars with staples versus sutures, and there's no difference. So they're basically equivocal long-term. In the short term, personally, I find the staples are faster. So certainly if we're in a situation where there's something else acute going on, I will always do staples because I'm not going to put someone else's health at risk over something that is going to have no long-term impact on you. Some patients prefer stitches, I think, because they feel like it's going to have a better cosmetic outcome in the end, but we don't have any evidence for that. And I think a lot of people get quite fearful around staple removal. I think it's actually much less of an issue than people think. I have taken out hundreds and hundreds of people's staples, and almost universally it does not bother them at all. And I've personally had them taken out and it was not terribly uncomfortable at all.
So people would expect that the sutures would always be dissolvable, but that they would see
in our center it is.
Okay.
But I have also worked places where they use sutures that aren't dissolvable that have to be taken out to close C-section. So I don't think that's actually universal either.
And that they would go back to their surgeon to have the staples removed. That's who would take them out.
For C-sections, typically in our center, family physicians and midwives are taking them out, typically because they're taken out around the same time as your well baby check.
Which is how long after generally?
So it's within a week. So yeah. So staples can come out a little bit earlier. So if you're someone who ends up with a bit more prolonged hospital stay for whatever reason, sometimes they'll be taken out before you even leave. And I've also worked in centers where there's actually home care nurses that come to your home and take out staples. It is one thing I like about staples is that somebody with medical knowledge looks at your incision within a few days of having the surgery, because that lets them help identify any early signs of complications that you might not be aware of. So I personally think that's one benefit to staples.
And will they always have like a bandage or a dressing that's over top, whether it be sutures or staples?
Right after the surgery, yes. And typically that's left in place for at least 24 hours. And then after that, typically not. There are some women, if you have big risk factors for a surgical site infection, sometimes we use a special dressing that stays on for a week to try to decrease that risk. But I will say the evidence for that is, we're hoping it comes out. It seems to work, but only in people who are quite high risk, because it's a bit more involved for patients and involves having to carry a little purse thing around with you, which can be annoying when you're caring for a brand new baby. But typically you don't need a dressing anymore after 24 hours.
So then I'm guessing that the nurses, or maybe it's the surgeon, but I'm guessing that the patient can expect someone will give them some information on what to look for after and what to keep an eye on it, and that they go home with that information.
Absolutely. So typically you actually get told it multiple times. So typically I, as the surgeon, go through it with you before you're discharged. The nurses go through it with you before you're discharged, and you're given a handout with the information as well. Because again, you're tired, you've just been through major abdominal surgery, and someone is giving you this new person to take care of, and you have to learn all of that, and it's quite an overwhelming time. So we do try to repeat that information as much as possible and give you the tools to be able to look it up if you've forgotten when you go home.
And then obviously, I mean, based on all those different layers of tissue that have been affected, rest is important. And I think sometimes moms have a hard time understanding, like, you hear rest, 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 but they don't always think about, why am I resting? And I always try to make it an analogy with something like a knee, because people understand their knee often better than they understand their abdomen or something related to their private parts. But just explaining how, if your husband went home after a knee surgery, you'd picture that they'd be spending a lot of time on the couch, leg elevated. You'd be doing a lot of things for them at the beginning, bringing them their lunch, bringing them, helping them mow the lawn, whatever. But can you speak to the importance of rest, and what, why do we use this magical term of 6 weeks? What are some of the things that the tissues need in that 6 weeks in order to feel, no matter how fit you were before or how active you were? I always say you can't rush a lot of that healing. So
No,
what do
you
you usually tell people?
So, I mean, I think that we are not as good at stressing that with postpartum moms as we are in with other surgeries, like full stop. I do think it's very important though. And I think listening, I mean, I usually go with the listen to your body, but also with the caveat that as moms, we tend to push ourselves. And so you need to kind of, like, if you're getting more sore, you need to rest. And certainly I think that if, like, resumption of activity too soon can certainly lead to a lot more pain and discomfort for patients, because things are, they have a big cut, and you still have a big cut inside, and you have big bruises inside, and things have been stretched, and that all takes time to heal, and there's inflammation going on with the healing, and that takes time to heal. And when we resume activity too quickly, you can certainly disrupt that and sort of end up making things longer for yourself in the end, I think.
Yeah.
But
I mean, I find a lot of people are kind of after 6 weeks, like, okay, what should I do with my scar? And often I say, you know what, that starts even before. And because, like you just mentioned, sometimes the more we do, we have pain, we have swelling, we have discomfort. That's going to be more inflammation that can cause more scar tissue. So even just being mindful at the beginning, so that you're not hitting that threshold, because I think we're quick to yes, I'm sore, but I had a baby, or yes, I'm sore, but I had a C-section. Whereas same thing, if it was your knee, if you were telling me you were having pain and swelling, I wouldn't say push through that. I'd say, well, that's information. Sounds like you need to get down and get your leg up. But I think we don't see it as a threshold for some reason. Yeah.
we should, but we don't. And I
Yeah.
think we need to try to work on changing that. Some of it is hard though. People don't necessarily have the same support after C-section that they might after knee surgery, unfortunately.
Absolutely. And I think that exactly. I wanted to ask you, because the last episode I recorded that was just released before this was all about compression and what the research is telling us about compression after C-section. And it sounds like there's a lot more research being published around this, around the benefits of less pain, more comfort, more mobility, less worrisome symptoms, or less catastrophization by women. And I know that's not something that, that the hospital provides right now. That would be nice if it one day did. But I wonder if, because this is something that I recommend very commonly for women after C-section, is compression. And most of them are like, oh my God, what have I been waiting for? I put it off because I thought, oh, I should have just worn it from the beginning. Now it's too late. And then as soon as they get it, they think, oh man, this would have been helpful. I wonder, and I know I was talking with in Australia, they're sometimes a little bit farther ahead with some of these things. Quite often, those women are purchasing compression garments before they go into the hospital. I'm just wondering your thoughts on, how do you see that being something that women could consider? Do you think that would be helpful? Yeah, what are your thoughts?
So it wasn't something I was very familiar with at all before listening to the podcast, but certainly after listening to it, I think it sounds like it could be really quite helpful. And I think anything that's going to help you feel more comfortable and supported during that time is so key. And particularly that there's some activities that you have to do repeatedly after a C-section that you never have to do after any other sort of major abdominal surgery. Like you have to sit up and pick up your baby repeatedly, because they need to eat every 3 hours, and there's not really anyone else that can do that. I mean, if you're trying to breastfeed, and even if you're formula feeding, typically your partner is not doing 100% of it. So, I mean, I certainly think that it could be quite helpful in that scenario. And I think it seems like it would be very low risk. I mean, in terms of, there's the cost of whatever you're going to use for compression. And then, I mean, as you know, on your previous podcast, they mentioned that there was, rare reports of having a contact allergy to the compression. But beyond that, I can't really think of a ton of risks. I mean, I would worry, in the context of if you're getting really sweaty under it, wearing it for hours and hours, that would be my one concern before you have a true, like when the incision is still open. Because I would worry about infection in that scenario. But beyond that, I can't really think of anything else that I personally, from a medical perspective, would have concerns about. And if it's going to decrease the amount of pain and increase your ability to care for yourself and this new human, I think it's sounds like really beneficial.
So I guess, like, on that note, and again, it's so hard to give this blanket information or black and white information, but would you say then, um I often say, like, ask your care provider, because I don't feel comfortable saying, oh yeah, no problem. But would you feel comfortable then if someone was interested in it? Is that something that you'd be comfortable with someone like myself suggesting, or would you rather talk to them on an individual basis about it?
Oh, I think I'd be comfortable with someone like yourself suggesting, I think.
Yeah. And like you said, you would be comfortable overall with it being worn early on, but you would just also, want them to still be mindful of checking for incisional areas, redness, swelling, pain, all whatever they feel. And like you said, giving it a break to air out.
Yes,
Right?
exactly. Or like, I think if you're going to wear it in the short term, I think wonderful for moving, wonderful for
Yes.
feeding your baby, but maybe not
All the time.
hours a day.
Yep, that's what I would suggest to someone anyway, is on and off. Like, and especially if you're going to be up a bunch, wear it then, but otherwise no. And obviously a difference between compression and waist trainers. There's so much marketing out there around waist trainers and cinching up your waist. That is something completely different. This is more, you can get anything from, sometimes people will say my high-waisted tights are enough, but quite often it's a bit more compression. It's so individual. And I think that's something, if you feel like in your budget is lower, then just try something that you have. But there's all sorts of things on the market, like the high-waisted underwear with compression, or the kind of like the little sleeves that go around you, tensor bandage type things. I might list some of the options in the show notes so people can look at some options that I find very helpful.
That would be great. I'm going to check them out too.
What's that?
Check them out too, so I can talk about it with patients.
Yep. I think that it would be good to have some options for people that they trust. Kate, is there anything that I haven't asked you about that you think would be helpful for someone listening? I always say what I really want these episodes to serve as or something that you would recommend to your patients, because I think this is something as our healthcare system is really busy and sometimes education is a piece that I think sometimes clients find is missing. I like these episodes to serve as something that helps you deliver some of the information that you repeat over and over and over again. So is there something that I haven't asked that you think would be helpful for people to know?
I mean, I think that the things that I usually talk about would be hospital stay afterwards. So typically hospital stay after a C-section is 2 nights, as opposed to typically 1 night after a vaginal delivery. And then, but we sort of say what we call full recovery, 6 weeks, but really that's just the point at which you are okay to start resuming more normal activity. But even then you're going to have become deconditioned over that time period. And so it's going to be, you're not going to be able to go right back to what you were doing before. And then in terms of the only other thing, yeah, I think that's pretty much it.
Yeah.
Yeah.
I think it's really helpful. I mean, as a physiotherapist, the reason why I'm interested in covering this is because I do see a lot of people that come in beforehand and they just say, I look at this as me knowing I'm going into an event like a surgery. And a lot of people just have a proactive mindset. I want to know how to set myself up for success physically, which always comes out as something mentally as well. But physically, I want to know what I can do before so that I can be smart as I get back to things after. And just so often, stress and the unknown and anxiety around all of this comes up in the appointment. And so I thought this would be a great way where I could say, hey, listen to this, because I think that this information is so valuable coming from someone like yourself. So I really appreciate you taking the time to do this.
My absolute pleasure.